Hello and welcome to all of you, and thank you for joining us for this first of 5 sessions of the JCoR SDG Lab for the 2025 High-Level Political Forum on Sustainable Development. My name is Teresa, and I am the coordinator of the Justice Coalition of Religious, or JCoR, which is a group of 24 NGOs who have accreditation at the United Nations to represent the mission of Catholic sisters, brothers, priests, as well as their partners in mission to advance human rights and environmental justice, or as is frequently said in the world of Catholic religious, to advance justice, peace, and integrity of creation through advocacy in international fora like those offered by the United Nations. So in our lab sessions this week, we will have one session each day dedicated to each of the 5 Sustainable Development Goals that have been selected as a priority for this year's UN High-Level Political Forum on Sustainable Development. And so we begin our lab sessions with today's focus on SDG number 3, which is to promote good health and well-being for all. And so we have with us today a panel of those who have been participating as digital delegates, and in some cases, in-person delegates of various members of the Justice Coalition of Religious during this year's HLPF. And they will be sharing with us some of their responses to their own review of progress toward SDG 3 in the countries that they come from. And in some cases, they will also respond to the reports that have been submitted by their own governments. And so you see on the screen before you the list of those who we will hear from today. And they include members of the Scalabrinian Sisters, the Claretians, Sisters of Notre Dame de Namur, and Medical Mission Sisters. And they will join us from different regions: the Dominican Republic, Nigeria, Germany, and India. So without further ado, I would like to welcome Maria Eugenia Vasquez, a Scalabrinian sister who joins us from the Dominican Republic to share her reflections on SDG 3.
Teresa, can you hear me? Good morning. Good. Thank you very much. Greetings, everyone. My name is Maria Eugenia. I'm here in the Dominican Republic, and I have prepared a presentation on the voluntary national review that our government has presented in this year's HLPF. Next slide, please. So in my presentation, I will try and cut it short due to the time constraints, but I'm going to try and speak slowly for the audience and also for the interpreters. I'm going to try and compare the report of the VNR of our government and compare it to the context that we are living in our country in the framework of the SDG 3. Despite there have been some improvements, we also can see that the new hospitals that are being built or renewed and updated, we see that those improvements are structural, but we see that there is a gap in the neonatal mortality rate. Since 2023, the mortality rate is 127 per 1,000 live births, which is a 25%, which is far away from the aim that the target that the government set for itself. And more specifically in the maternal mortality rate, and which is also the mortality, the birth mortality rate, there is a lack of measurement of measures taken by the government towards the migrant women, especially coming from Haiti, that are giving birth in our country. We have seen a setback in the advancement of the government, because the government is supposed to be taking steps towards solving that problem, but we see that there is that situation has gotten worse. When we study the under 5 mortality, it remains around 31 per 1,000 live births, 8 points above the global target of 25 per 1,000. Despite the government having put in place a lot of programs to combat diseases, sexual diseases, and especially AIDS, the US government has taken some measures that have affected the Dominican Republic, because there is a lack of funding of certain hospitals that had an agreement with the states. And so the gap is growing at the moment. And the situation has gotten worse since 2024. We have seen cuts in the budget, and we are afraid that the final result of 2025 is going to be even worse than in 2024. So in the VNR of our government, we saw no information of 2024. The data finished in 2023, so we cannot really analyze if the percentages are gotten worse or better. It is true that sexual and reproductive health services have been strengthened, but these Haitian women I was referring to before were not taken into account in these new measures. And of course, the VNR did not mention the women traffic, especially coming from Haiti, Haitian women. And the Ministry of Women, which is existing in our country, did not mention this either. Maternal and neonatal health, there is a new program by the government on maternal and neonatal health, but the government has mentioned these programs as their own, when in fact they have been organized and they are being carried by private groups. And they depend on external funding, of course, and these programs were also highly impacted by the new policies in the United States. In the present context, migration measures taken in hospitals, especially after April, hospitals have become a migration control center. And that means that migrants, first and second generation migrants, especially from Haiti, are not coming to hospitals, which is widening the gap even farther when we think about illnesses, pandemics, and pre and postnatal healthcare. Next slide, please. Oh, and about public spending, which is one of the informations that the government mentioned in its VNR. The VNR justifies somehow this measure that they have taken against migration in hospitals, because they pretend that the Dominican state was never able to contribute a 4% of the internal revenue to health, which is the target. The contribution or the part of the internal revenue that was devoted to healthcare system never went farther from 2%. Next slide, please. I don't want to speak too long. Next one. In the VNR, it says that 2019, the public expenditure was 1.9% of the internal revenue. The commitment to the universal right to health and resilient systems within the framework of the Pact for the Future is not being held. This is the reality. There is a persistence of inequalities in health care, which reflects that beyond institutional reforms, structural barriers related to the country's social inequalities persist. And this is not mentioned in the report. We are witnesses to that. Next one, please. I wanted to stress that hospitals have become militarized, especially maternity wards. There is a lack of prenatal and other types of care, and there is a growing fear among migrant populations and other populations, because hospitals are becoming migration control centers, and this is affecting care. Care is even denied to people that have no legal documentation. So vulnerable populations, migrants, minors, and women are suffering under the implementation of these policy measures. And doctors are assuming the role of immigration agents. Next slide, please. Well, here you can see some numbers, statistics. The number of Haitian women in gray, and in blue the total amount of delivering women in hospitals. Next one, please. Because I'm worried about time. So deportation of pregnant women identified in public hospitals is an act of absolute inhumanity. A violence that cries out to heaven and has provoked widespread condemnation from broad sectors of the population and of internal organizations, including the UN and the Vatican. The presence of immigration officials in hospitals becomes an unsurmountable barrier for women in urgent need of medical attention. This has devastating consequences: avoidable deaths, the worsening of health conditions, and the risk of a public health crisis that could affect the entire population. The argument authorities use to justify this practice that childbirth represents an unbearable cost for the country. And according to insurance rates, the average cost of childbirth in public and private sectors is an average of 51,000 pesos. Next slide, please. I'm coming to an end. Next slide, please.
No se preocupe con el tiempo.
Don't worry about time. Can you show the next slide, please? So Dominican Republic's public health expenditure for 2023 was only 2.7%, the second lowest after Guatemala, according to studies by the Wilfor Institute. according to the Law 0112 on National Development Strategy, 4.5% of the GDP should be allocated to health, but in 2024, the investment did not exceed 2%. At the moment, the Public Health Institute is undergoing a financial crisis, and the national insurance is owing over 2 million pesos, and you can imagine this is public insurance for everybody. So the healthcare is practically inhabilitated due to this financial crisis, and this is a reality that also impacts the most vulnerable population in the Dominican Republic, not just migrants. Next slide, please. The vast majority of these pregnant women do not come from Haiti. They live here in the country. They have been living here for years, even longer than 10 years. So they've been living in the Dominican Republic for over 10 years. And I just, while Teresa shows the next slide, I wanted to explain that the Dominican Republic in the Americas is the first country with the highest level of people without a nationality, which is affecting also, I mean, this situation is affecting migrants, people that have no nationality at all, but also the most vulnerable parts of the Dominican population. Here you can see the documentation control at hospitals. If these mothers are coming without the documentation, they can be deported and they are denied care. So that's why women are deciding to deliver their babies at home. And on the right, you can see a child that had an encephalitis, a huge infection in the brain because the umbilical cord was cut in the wrong way at home, and they had no healthcare there, of course. Next slide, please. The majority of Haitian women or extremely vulnerable women from the Dominican Republic are subjected to, well, they are very vulnerable, so they are subjected to violence, human trafficking, inequality, violence coming from police sometimes. I always say that migrant women are always in an extreme situation of vulnerability because they are migrants and because they are women. Next slide, please. Children are being born without a proper healthcare, but also without a proper nutrition because mothers arrive at hospitals in a really famished state. So our country has a real health crisis. We have migrants that are really dying of hunger in an extreme violent situation. So I believe that this is impacting not just the healthcare system, but when we talk about this SDG and in the Dominican Republic, we should have a look at part of the population, which is a population that is in an extreme vulnerable situation, which are women, migrants, and their descendants. And this is enlarging the gaps and affecting SDGs 1, 3, 5, and 10. It is closely linked to poverty because the poverty rate is increasing. It increases gender inequality and it affects the reduction of inequalities in general. So when public policies are are designed, the point of view should be broader, as I'm showing in this image. Next image, please. In the next slide, you can see a woman that delivered at home and everything went okay, but she has no documentation, so she cannot register her child because the child was born at home. And so the child is again is going to become one of these people that have no country and no nationality at all. Nevertheless, we still have hope, because we know that there are a lot of women that are being trained to become doulas or midwives to help these women that are delivering at home. And we are offering these kind of courses as well. And that's all. Thank you very much.
Thank you very, very much, Hermana Eugenia, and what an impactful and important observation that you've shared with us. Particularly, I'm struck by how you've illustrated the intergenerational expansion of inequality that we see arising from this barrier to access to healthcare, which is the requirement of documentation and proof of citizenship or some other document that authorizes one to receive urgent medical care. And you've painted quite a clear picture for us, and especially highlighting that in the Dominican Republic, where you have such a high rate of people without documentation for different reasons, whether they are migrants or only children of migrants who may have been born in the country, or others who maybe are multi-generation residents of the country, lifelong residents of the country, but whose birth was never registered. And as you say, this burden, this lack of access will continue to fall disproportionately on migrant families, on women, and on children. And so, of course, this is great concern, and so important that we understand and continue to emphasize that it is a right. Everyone has a right to a nationality. Everyone has a right to have their birth registered and documented. So we continue to fight that on a systemic level, even as you and your sisters and your partners provide immediate care in all of those urgent situations. And we thank you very much for that work. And next, we will hear from a Claretian missionary in Nigeria, Cletus Uche, who will also share his perspective on SDG 3. Cletus, you have the floor. Okay, it seems we may have lost Cletus, so we will go to our next speaker for today, and we hope we will see him again later on. So we will go next to a team of two sisters of Notre Dame de Namur, also coming from Nigeria, Sister Rita Ezekwem and Sister Julie Mokidi, and they will share their experience and analysis of SDG 3. Rita and Julie?
I want to find out, Rita, are you seeing my screen?
Not yet.
Hey. Shit.
Oh, here it comes.
It's coming. I can make it bold. Can you see it well? Or do I
We
have
do,
to?
but it not the full screen. Can you put it into slideshow?
All right. Yeah, it's
I think that's all. That's
I want to see if I can. Oh, right.
Down right side near the book.
Sorry.
think
Down right side where minus plus is there, left side of the minus.
Okay, let me see.
Just to the
Someone
left of that, you'll see a small picture of a
left. No,
projector.
no, left.
Go to the
left
left, go to the
icon.
left of that whole bar. There is a small image of a
Icon
little
is there.
rectangle.
And the Zoom itself.
No, no,
Where-
no, in the PowerPoint where you were.
That's
I'm showing us.
Teresa, may I ask you if you can share what I sent to you?
Yes, sure.
Thank you. So I stop sharing.
Yes.
Okay. Okay, good afternoon, Teresa, and good afternoon, colleagues. Nice to share our lived experience in the area of SDG 3 from Nigeria. Julie is currently in the States, so she will begin and I will conclude.
Okay.
Thank you.
Good morning, good afternoon, and good evening to everyone. I'm Julie, I'm a sister of Notre Dame. So the Sustainable Development Goals, the Sisters of Notre Dame have lived them before the UN formulated them, or before they came into existence through various ways, through establishment of hospitals and clinics. Go to slide 3, slide 3. In 1804, Saint Julie and Francois founded the Congregation of the Sisters of Notre Dame in France. And the main purpose was to educate poor children. But moving with the signs of times, they diverge into other aspects like the healthcare system. So the mission expanded to healthcare. The next slide, please. So today, the Sisters of Notre Dame live and work in 15 countries across the 5 continents, and they continue to minister to those who are impoverished through education, healthcare, pastoral services, and social work. Next slide. Next slide. So how the Sisters of Notre Dame came to Nigeria. A sister of Notre Dame from the British province by name Sister Josephine Murray was asked to give a workshop to the northern bishops, and they were impressed with what she did, so they invited the Sisters of Notre Dame. So on the 17th of January 1963, the first 3 sisters came to Nigeria to stay and to establish their presence in Nigeria. Next slide. So the early mission of the Sisters of Notre Dame was merely to catechize the people, to teach in schools. But with time, as the need arose and the sisters began to open schools and have boarding houses, there was a need to open hospitals to cater for the needs of the students and the people around. Next slide. Hence, the first hospital was established in Amoyo in Kwara State in 2009 in connection with the SDG. It was to minister to the local women. At that time, when this was opened, the sister started a mobile clinic in which they go to villages to administer first aid, talk to people who live in the creeks, who have no access to quality health care. The sisters provide mobile clinics to these people, especially in the abandoned places where those places were not even motorable as at that time. Next slide. So recently in 2023, the sister opened a new hospital in Enugu State. This was to cater for the needs of the people as well, because there was no hospital there. The nearest hospital was 5 miles away from the vicinity. This hospital created employment for the people and cater for the needs of the women and children and the most vulnerable, and also the students as well. The hospital also collaborates with pharmaceutical industries to make sure that good drugs are provided for the people, because in the country nowadays, there are a lot of fake drugs around. A lot of fake drugs. I give example with my mom. My mom was sick for just a week, and the first hospital she went to, they had administered fake drugs, and they were treating the wrong. They were giving her wrong treatment. They could not diagnose the right treatment, because this is due to people are migrating. The educated ones, the learned doctors, most of the we don't have doctors in the hospitals in the villages. So the sisters feel in this need. They feel in this need. That's one of the aspects that the sisters have worked at. And the sisters also came to take my mom to a better hospital where the sisters also administer care to other people. Next slide. So this is the hospital where the recent hospital that was built, as you can see in the photo. So I give the floor to Sister Rita to continue.
Okay, thank you, Sister Julie. Yes, going by, with what she said about fake medicine in the country, we remember the story of Professor Tora Akunyane, who worked very hard, fought for all of that, but it's still on the increase. So the sisters established this not only to give medicine to the locals, but also to carry out normal operations, that a lot of mortality when people go for surgeries because of fake drugs, and some on the trend doctors. A lot of good doctors have migrated to the US, to UK, to everywhere, and every day more are still going. Next slide, please. The hospital has an adequately equipped theater, as I mentioned, that they carry out a whole lot. As Julie said, wrong diagnoses, even among sisters, will go to hospitals. And I remember a sister that has been treated for she's been on treatment for a long time because she was diagnosed of liver failure, organ failures, only to find out that she had none of that. And she has taken a lot of medicine that were not supposed to be in her body. So the pharmacy section in our hospital, we have a very trained, well-qualified pharmacist with an up to standard stock of medicine run 24 hours without the help of the government. Some of the services offered in our hospital pharmacy includes drug dispensary, prescription transcriptions, and we partner with good pharmaceutical companies that we know in Nigeria that are producing good drugs. Next slide, please. So you can see where our lab section, where everything that any sister of Notre Dame anywhere can beat their chest and say, oh, this is because we believe in God's goodness, as our foundress will always say. And we want to make a clear statement that we are for the poor, absolutely for the poor. Next slide, please. Next slide. You can see some of our students, I mean, just one out of taking care of. Our boarding facility, it's well established and well funded, that the children in our schools are well taken care of, aside the other patients that come, especially those from the rural of Okonano, where the hospital is established, because it's a middle and low class people that are living within that vicinity. Next slide. You can see a pharmaceutical session, just I think one part of it. And we are very proud that our people are getting the right treatment. Next slide, please. See waiting room. In some hospitals, you don't get this kind of facilities. Oftentimes you see a small, maybe one room, it will be both for consultation as well as, except in big cities, and the majority of the poor people cannot afford to go to such hospitals. Like I'm working in Abuja, I can tell you that some good hospitals here, you can pay a consultation fee of 10,000 naira. And for the poor people that want to seek for this, they don't have the opportunity to, they don't have such money. And we are hoping that after Enugu will be coming to Abuja, just to give to the people of the area where we are working the opportunity to get good health treatment, health care. Next slide, please. The hospital collaborates with doctors and other external medical personnel because they believe in what we are doing, such as gynecologists and other experts, to handle complicated cases with utmost expertise. To provide also quality medicine at an affordable price, the hospital pharmacy sources its medicine from trusted companies, as I mentioned. And most of these companies, they also donate. They also give as part of their corporate social responsibility. At the inception of the hospital, a company like Jewel donated medicine to support the work of the sisters in the hospital. In our little way, we collaborate with the government in ensuring the provision of standard medicine and the injection of and the rejection of counterfeit drugs. It's actually it sounds so easy as I'm talking about, but to work with government in ensuring that you have the best is usually a big challenge. But the sisters have, over time, within these few years, that hospital opened, and other places where we have the outlet have stood their ground to ensure that they get the best and the correct medicine for our patient. Next slide, please. And the challenges are in the course of sharing. We also say that the pharmacy, as a part of the hospital, has the potential to offer more extended services such as drug therapy monitoring, pharmacovigilance, compounding all of that with further capacity building, which is lacking at the present in some of the hospitals around. The failure to provide a constant cooling system for the medicine on the shelves, as well as those that need refrigerator, causes a break in the cold chain and deterioration of medicine, especially during the hot season. As we know that Nigeria, we have, yes, the weather in Nigeria is quite hot. Furthermore, with the recent menace of insecurity coupled with economic and social political instability, a lot of pharmaceutical companies with high-tech good manufacturing practice and top-tech quality products have begun to leave the country in droves. As I mentioned, a lot of them are looking for better options in the Western North. This leaves the local companies struggling within the dwindling economy to provide the medical needs of the enormous populace. Yes, next slide, please. There's a lacuna created by this by the inability of and the loopholes and the upsurge of, as I mentioned, with NAFDAC fighting every day. Currently, last 2 months in Onitsha, they closed down a section of the drugs and the medical section because it was massive, the amount of fake drugs. And this particular section is the section that supplies drugs to every part of the country, almost in the southeast. So some of the challenges emerging as a result of this are skyrocketing prices of medicine, which they call the good ones, making a dream of providing the best quality medicine at the cheapest price for the poor people. And it seemed almost a tall dream. For instance, some drugs, as we can see, which is a medicine for the management of pain, was sold at the cost of, I don't know how, I can't convert it now in dollars, but 8,000 naira per pack in January this year. In the last month, June, and the price has gone to 18,000 naira, and presently is at 23,000 naira. And if we're able to check today, it may have jumped to 30,000 naira. There are other similar, examples like that. And yes, some of the sick ones and poor ones need to be treated with this very expensive medicine, just like what Sister Julie said. And oftentimes you see somebody that has small malaria, next week you hear the person has gone because the medicine given is not doing what it's supposed to do. A lot of fake drugs. That's actually one of the most challenging, aspects of the healthcare in Nigeria. And our sisters are doing what they can in the midst of all of that, in the midst of these fake things, and still remaining true to our mission and ensuring that our people get the best. Next slide, please. The crossroads. First, with this reality, the questions that come to mind: what do we do? In the face of proliferation of counterfeit and fake drugs, how can we continue to provide standard quality medicine to the poor people of our neighborhood at affordable rates? How can we continue to be present to our sick pupils and students, to offer health education, and to be present to the other sick, poor ones, even in the most abundant places? And even in schools, for you to get a good doctor that can be coming to see the student for some obvious illnesses, some of them cannot afford it. And we try as much as possible to offer it, but for how long, and the support, where and how. How can we continue to implement this SDG 3 within the context of our reality? We live with hope, and in conclusion, it is hope and the grace to continue to remain true to giving health care to our people and promote their well-being. Thank you. Merci beaucoup. Gracias.
Many thanks to you, Sister Julie and Sister Rita. And I know this is not one of the most commonly spoken about phenomena when it comes to providing healthcare. Normally, we think a lot about the facility in which care is provided and the personnel that are available, which you did mention are both challenges, especially in remote areas. But it's an important additional piece you've mentioned, this ongoing struggle to ensure that medicines that you have on hand, that you're able to obtain, are even safe and proper. They're not fake or counterfeit versions of the medicine that you were seeking to provide. And that again brings to mind, the need for systemic support, because there are challenges in terms of infrastructure, in terms of trade and economic arrangements. You mentioned the need for greater chain for refrigeration of certain medications, which requires big infrastructure and big support on an energy sector level. You mentioned that some companies are leaving the country due to economic arrangements, trade arrangements. And so that makes it more difficult to have access to safe medications. So all of this illustrates how impossible it is to address challenges related to health simply with all of the goodwill and even all of the skill that sisters and their partners may bring to a community, that there is still much need for support on a much larger and systemic level. And so there's great need for partnership with and support from government to make good health possible. So thank you so much for illustrating this situation in Nigeria for us. And now we will continue to hear more about Nigeria because we have Cletus back with us. So once again, a Claretian missionary coming from Nigeria, Cletus Uche, you have the floor. Yes, sorry, we do hear you. I was deciding which one to begin. I believe you want the VNR one first. Okay, great. Okay. I'm putting it on the screen now. Yes, one moment. Okay, proceed. Thank you very much, Cletus, for your analysis of the data and the reporting that came from the government, as well as that sharing on the impressive contribution of the Claretian missionaries and your partners to the sector of health. And I see, such an impressive variety of different health services that are being provided by your community there. And not least of all, trying to address one of the challenges that Sisters Julie and Rita mentioned, which is that there's a constant outflow, it seems, of medical professionals with qualifications. And so that you are providing more, training more, and creating a presence that makes their long-term presence and employment possible in communities that are in need of those professionals is such a vital contribution, along with all of the practical services you are offering and the observations that you are making to the bigger structural challenges. What are the persistent bigger problems that need to be addressed across different health facilities, across different communities, especially matters of chronic health conditions where you see those kind of pervasive across a whole nation or a large region. It brings into question, what might be the systemic causes of this chronic illness when so many are related to, say, nutrition or other environmental factors. So this data that you're collecting, the observations you are making are so vital to be able to address some of those root causes. Thank you very much for your sharing. All right, and now staying with the Claretians, but moving to an entirely different country and an entirely different region, we will hear from Neelam Turkey, who is another Claretian missionary who is originally from India, but is on mission in Germany and will offer his insights related to SDG 3 in Germany. Neelam?
Good morning, good afternoon, and good evening, Teresa and colleagues. I am Neelam from India and at present working in Germany. I am going to narrate about SDG 3 and SDG 5, health and well-being and gender equality. SDG 3 deals about healthy lives and promoting well-being for all at all ages. The German Sustainable Development Strategy, first adopted in 2002, forms the basic for German sustainability policy. Since 2016, the German Sustainable Development Strategy has been aligned with the 2030 agenda and its 17 Sustainable Development Goals, and thus serves as the national plan for implementing the agenda. The current update version of the German Sustainable Development Strategy, adopted by the Federal Cabinet in January 2025, pursues a systematic approach to sustainability policy. Germany has defined 6 integrated areas of transformation and 5 levers, 5 pedals, which take the connection and interrelationship stakeholder contribution between sectors into consideration. In order to promote active, targeted steering of the transformation process, transformation teams in the form of temporary interministerial project groups were set up for the areas of transformation and the international responsibility and cooperation. With the involvement of various social factors, the work of the TTs has given rise to 7 transformation reports, among other things. Thus, the reports were adopted by the cabinet and fed into the process of adopting the German Sustainable Development Strategy. Germany's commitment also includes measures to implement the United Nations Decade of Healthy Aging. In line with the 4 areas for action identified by the World Health Organization, this particularly includes measures to promote an age-friendly environment, combat loneliness and ageism, and guarantee the provision of quality care and support. This SDG in Germany is connected directly with health insurance, either by the government or private health insurance sector. Health insurance coverage are diagnosis, that is doctor consultation, medical checkup, intervention and medication, cure and rehabilitation. In my viewpoint, there are some other points to be discussed. There are lack of healthcare workers. Germany has a significant and growing need for nurses. Current estimates indicate the shortage of at least 150,000 nurses. Projection suggests that this number could rise to 3 lakh by 2029. This shortage is driven by an aging population and the increasing demand for healthcare services. The German government is actively working to address the shortage by facilitating the integration of foreign nurses. Germany is actively recruiting nurses from other countries, including India. In Germany, nursing students can receive financial support through various avenues, including scholarship, stipends during training, and potentially even free tuition at some public universities. Additionally, there are opportunities to earn a salary while undergoing nursing training through the Ausbildung program. Some of the programs which support students are DAD, that is a German Academic Exchange Service, and another one is that gives a scholarship for the foreign students. Then stipendiums. Nursing students in Germany, particularly those in training program, receive a monthly stipend during their training, which can cover living expenses. For example, those who are in training program, they get 1,191 euro or till 1,353 euro per month. And apart from that, their tuition is free. Some universities offer nursing programs with tuition free, while others, particularly public universities, offer free or very low cost tuition, especially for German citizens and some international students. In Germany, maternal mortality rate is very low, that is 4%, and that is started from 2019 till 2025. The ratio is 4%. Health promotion and prevention. German's health promotion and prevention program focus on a wide range of areas, including early childhood support, workplace health promotion, and addressing social and health inequalities. These programs are integrated into the German healthcare system, which emphasizes preventive care and health literacy. Key aspects include the decentralized federal structure, collaboration between various factors, and focus on practical application of knowledge. I have also noted some of the challenges and future directions. Funding. Ensuring adequate and sustainable funding for German health promotion and prevention is very, very crucial. Integration. Better integration of different levels of the healthcare system and different factors are needed. Digital health adoption. Maximizing the potential of digital tools for health promotion while addressing potential barriers to adoption is important. Health and well-being affects because of there are so many homeless people, homeless population. The Federal Ministry of Housing, Urban Development and Building has presented figures showing some 5,31,600 people are without a permanent shelter in Europe's largest economy, Germany. The Federal Ministry of Housing, Urban Development and Building, which presented the new figures on Wednesday last year, couple of days back, explained the almost 100% increase was down to underreporting in the previous paper, but this is now gradually being corrected. Addition to the homeless people, there are 136,900 homeless people are from Ukrainian refugees. Now I would like to present from in other perspective, that is gender equality. German government has tried to bring gender equality through constitutional and legal framework. Germany's constitution ensures equality before the law and prohibits discrimination based on sex, origin, and language. The constitution was amended to explicitly state that the state promotes the actual enforcement of equality and aims to eliminate disadvantages. Several federal laws address specific aspects of gender equality across different sectors. The General Act on Equal Treatment invalidates previous that infringe upon the ban on discrimination in work life. Apart from these acts, there are also some facilities like which can be afforded both men and women. For example, maternity leave or parental leave 3 to 8 years. In Germany, there is not separate dedicated paternity leave for men in the same way by the maternity leave for women. However, fathers are entitled to take parental leave under the same general rules as mothers. This parental leave can be taken at any point up to the child's third birthday or even later in certain circumstances. That is very good about Germany. Another one is gender equality is behind in Germany, especially when we talk about labor. One way to measure gender equality is counting women in leadership roles in companies. Though an imperfect measure, since it does not count all women in the job market or take gender pay gaps into account, the idea has caught on. Looking at 160 big publicly listed companies in Germany in March 2025, women made up 19.7% of their executive leadership teams and 37.4% of their boards of directors, according to the report by the AII Bright Foundation. So CEO, women are 4.4%, men are 95.6%. Chair of the board, 6.3% are women, 93.7% men. Member of executive leadership team, 19.7% women, 80.3% men. Member of the board, 37.4% women, 62.6% men. At the end, I would like to give a small detail about gender pay gap. In Germany, there is a notable gender pay gap with women earning less than men on average. Especially, women in Germany earn 18% less than their male counterparts. This translates to men earning an average 24.36 per hour and women earning 20.05 per hour according to DB News. The gap varies across different sectors and industries. And some sectors like construction and engineering being more male dominated, and others like healthcare and social service having a higher promotion of women. Overall, Germany has a strong legal and policy framework for gender equality, but societal attitude and deeply ingrained stereotype continue to pose challenges. Efforts to address the gender pay gap, increase women's representative in leadership, and promote work-life balance are ongoing. Closing the gender data gap is also crucial for effective policy implementation. These were some of the observations in SDG 3 and 5. Thank you.
Thank you very much, Neelam. And how interesting to hear, in some ways, potential connections between health challenges that were being described from our friends in other regions, particularly in Nigeria. It was emphasized that doctors and nurses were moving out of the country. And here in Germany, there are programs to incentivize nurses to come into the country and to receive training in the country. And so you wonder, maybe there is some kind of arrangement, international arrangement that could be worked out in terms of partnership to help kind of spread around more the wealth of highly trained professionals. And I also want to highlight your other point about having lack of housing or lack of a registered address as a barrier to receiving healthcare, which is a significant concern in Germany based on the statistic that you shared about the large number of people who are currently without housing. And I believe you also mentioned that within that community of those who lack housing, that it is either majority or disproportionately those who have migrated from other countries, possibly Ukraine. That's a large population. So many intersecting challenges. And thank you also for bringing in your observations related to gender equality. Those were some really stark differences, at least at the highest level of business leadership, some very big gaps in the representation of women and men. So just to say, even in a country that perhaps might be recognized as being one of the leaders in gender equality, we still see that even with some truly positive structural policies in place, there's still much work to be done to really realize that equality. So thank you very much for all of those observations.
Welcome.
And finally, today we will hear from Sister Babita Kumari, who is a medical mission sister who is joining us from India and will be sharing her observations on SDG 3 in India. Sister Babita?
Yes. So, good morning to all in New York present in person. Good afternoon and good evening to one and all on Zoom on different times that we have. As I read the report and listened to India's voluntary national review, I found it to be very remarkable, comprehensive overview of the government's achievements and its proposed path forward. The report is very positive and impressive, but it also gives the impression that there is little room for improvement, and the tone suggests that most issues have already been resolved. The specific headings mentioned in the report, such as societal approach, SDG localization, strengthening universal healthcare, affordable healthcare services, digital healthcare programs, points an impressive picture of progress, and it gives the impression that all targets have already been met. There is no doubt about it. A great areas and great number has achieved, but not to the maximum and the way it has been presented at the national review. Many of these achievements primarily benefit, according to me, the rich, the middle class population, while much of the poor population still and to access quality healthcare remains an unfulfilled promise to a greater extent. In my experience, working with refugees, migrants, Dalit, women and children, families affected by HIV/AIDS, I have witnessed firsthand the persistent health challenges they face in places Bihar, Madhya Pradesh, Delhi, and Pune, Maharashtra. While I acknowledge the government's progressive voluntary national review and recognize commendable efforts such as the expansion of the immunization program and increased rates of institutional births in both rural and urban populations, leading to a decline in infant and neonatal mortality. The reality on the ground is more nuanced. The immunization is important, but it's just one facet of broader spectrum of health requirements. Nutrition meals provided for the good health and well-being of everyone at Anganwadi centers are a very good initiative. People, it's a very good program. Women, children, pregnant women, lactating women, youth are very much taken care at this time. Good ration is distributed. The immunization program, the immunization takes place over there. However, in all that, due to widespread corruption and mismanagement, many centers fail to function effectively. The way the Anganwadi is there, if it really sincerely it is functioning, a very good and effective things will happen over there. Although auxiliary nurse midwives are present at these centers to offer basic services to overall in health infrastructure remains minimal in many areas. The disparities between policy and implementation continues to impact the most marginalized group. Our country has introduced various healthcare schemes that are commendable, very good, and really, really good. But in that process, largely it benefits the rich, the educated, and urban population. However, when compared to the rapid advances under the initiatives like Digital India, these immunization schemes feel insufficient and outdated. They address only the most basic and long-standing needs. Though policies targeting reductions in maternal and neonatal and under 5 mortality rates show measurable success. Access to affordable health care for the poorest remains a distant goal. Immunization being one of the few broadly successful efforts. We are very happy that the government in this process has a scheme which provides maternity leave for 6 months for women and also for men the parental leave. Incentives for pregnant women, ASHA workers also has a positive impact which helps largely for the institutional birth care. Digital healthcare, as mentioned in the Vienna, the Ayushman Bharat Digital Mission is a promising step towards a citizen-centric health ecosystem, but its reach remains limited to urban and elite demographics. With the majority of population residing in rural areas, efforts must be expanded to bridge this digital divide. National Aid and SDG Control Program, while official figures suggest an 80% reduction between 21 and 2026, but still they rely on private pharmacies due to lack of supply in government facilities. The most pressing healthcare issues lie within hospitals. There is a lot of filling of gaps for the nurses and doctors. Yet, there is also severe shortage of trained professionals and poor patients often lack access to essential medicines. Infrastructure is great, yet infrastructures in rural areas exist, namely named only on many facilities are either non-functional or poorly equipped. Today, the health sector increasingly operates as a commercial enterprise, with private clinics, corporate hospitals, and diagnostic centers dominating the landscape and often exploiting the poor. Crucial dimensions of health, such as mental well being and support for differently abled children, also remains severely under-addressed. Many local health centers suffer from non-functional diagnostic machinery and poor infrastructure, as I mentioned, especially in northern India, where quality care for ordinary citizens and children in particular is still a distant reality. It's a question to be thought: how can children or the people be healthy when the planet they inhabit is unhealthy? There is an urgent need to foster environmental consciousness as a core element of public health. In the face of rising commercialization, the relevance of government hospitals operating under a multi speciality model must be re examined. We need to transform hospitals and health centers into place of healing, not only medically, but socially, psychologically, and ecologically. The core issues in our country lies in the sincere and effective implementation of government schemes meant for people. The entrenched VIP culture and political interference in our country often hinders equitable access to health services, particularly for the poor who deserve care without discrimination. In Vienna report, it is mentioned about the societal approach. The government claims to have engaged civil society in preparation for the Vienna report. Yes. However, civil society groups that critically challenge policies, especially those policies affecting the poor, to ensure genuine grassroots representation and equitable development are hardly accepted by the government. Unless the government is open to critical feedback, the societal approach will not achieve. Partnership. Yes, India presents itself as committed to regional and global partnerships. Yet this often translates into increased out-of-pocket expenditure for individuals. Government hospital partnerships with private entities have led to partial charges, which still burdens economically vulnerable groups like children, migrants, Dalit, tribals, and refugees. True partnership must prioritize access and affordability for the marginalized. In conclusion, to address the shortage of health professionals, the government has indeed taken steps such as providing incentives, as I mentioned earlier, to ASHA workers in both rural and urban areas. However, there remains an urgent need to fill vacant positions for doctors, nurses, and paramedical staffs, especially in rural regions. Government programs must be monitored and implemented meaningfully at the ground level, not merely for record keeping or data collection purposes. Far too often, efforts are conducted for the sake of reporting rather than genuine impact. It's crucial that the government actively engages civil society, particularly those working directly in remote villages, and seriously consider their perspective to improve service delivery. While the emphasis on data is commendable, it should not overshadow the importance of everyday implementation. The government must remain open to suggestions, constructive evaluation, and feedback to ensure real progress. Holding authorities, government officials, local leaders, and decision makers accountable remains challenging but essential. As a nation, we must begin to look beyond hospital walls. Health is not confined to clinical spaces. It is deeply connected to living conditions, equity, and dignity. If all health institutions functioned as envisioned in the government's Vienna report, civil society would wholeheartedly celebrate and support these efforts. Thank you.
Thank you, Sister Babita. And what a good overarching remark to conclude and really to summarize so many of the sentiments that have been shared today, which is to say, you know, here we are as many communities of goodwill who are providing professional services, who are providing infrastructure and facilities and professionals and resources, and we share the goals that are on paper when we are talking about the Sustainable Development Goals. And yet, from our perspective in communities like those who are in rural areas and who are often the last to receive, you know, innovation in any area of development, especially health, those who are the most distant from facilities or for whom digital access to new and innovative programs remains out of reach as long as internet is out of reach. For communities with special needs like those with disabilities or who face other forms of social discrimination, whatever it may be in each context. And so here we are ready to do the work and wanting to make real the vision that is there in the Sustainable Development Goals. It's there, as you were saying, in many of these health-related schemes of the Indian government, and still it is not real for the communities that we serve. And so we must continue to shine light on the ways in which it has not reached those communities, and to say, you know, you have the right idea, the vision is there, the program is there, but it's not making the connection. It's not reaching those who are in the greatest need. And so when you give us data, you know, let it be disaggregated in a way that shows how does it impact or how does it benefit this community, the rural community? How does it impact the Dalit community? How does it impact migrants and children and people with disabilities, and on down the list, and make those the priority. And so we do not become too impressed or too satisfied with improvement for those who are the least vulnerable and who have the most resources and who are in urban areas. So thank you very much, all of you, for your contributions, both in the sector of health, to which so many of you and your communities are contributing directly, and helping to make goal number 3 real for communities around the world. But thank you also for taking the time and the effort to step back from that important work and really analyze the big picture, to see the systemic structures and strings that connect it to other challenges, including environmental, including migration, including gender, so many facets, which all interconnect. And thank you for sharing with all of us so that we can learn and we can help to transform those structures toward justice. And I will invite you all to join us again as we embark on our second session tomorrow, which will be dedicated to another SDG. So we will move on from today's focus on health. And tomorrow we will have a focus on SDG number 5, which is to achieve gender equality and to empower all women and girls. So we hope you will join us again tomorrow at the same time as today to hear from even more members of our global community and to gain more insight on how to realize this important goal. Thank you all once again for being here. Thank you to our interpreters, and we hope to see you tomorrow.
Thank you. Bye-bye.
Thank you.
Thank you, Teresa, for the energy you
Okay,
have
thank you.
all this while. Thank you. And thank you, co-presenters.
Gracias, Teresa. Gracias a todos los que
Thank you. Bye.